Today we're going to speak about the arterial switch operation for transposition of the great arteries. Now, transposition of the great arteries really represents one of the big success stories in management of congenital heart disease. Many years ago, even after identification of the anatomy of the transposition, this was a uniformly lethal lesion in the first year of life. And then there were evolutions of surgical repairs, first palliations, later repairs in the early days of open heart surgery that gave way to different types of repairs, the arterial switch that we do now, as the field evolved to be able to take care of children at a younger age and to take on newborn open heart surgery. First, let's talk about the anatomy and physiology of transposition. As most of us know, the anatomy or the physiology is such that we have systemic and pulmonary circulations in parallel rather than in series. So again, the basic anatomy, stepping back, is that with transposition of the great arteries, the aorta arises from the right ventricle, the pulmonary artery from the left ventricle. So blood returning from the body goes right back out to the body. Blood returning from the lungs is sent right back out to the lungs. Two circulations in parallel. This results in cyanosis that's unresponsive to oxygen administration. All the blood that's going to the lungs is getting adequately oxygenated. It's just not heading out to the body. So giving more oxygen won't improve systemic oxygenation significantly. There has to be mixing between those two circulations to sustain life. It's mandatory. And the typical levels that are required are either the atrial septum, the ventricular septum, or I put in there parenthetically a PDA. And the reason I want to stop and emphasize that for a second is that it's important to recognize that a PDA alone is not sufficient to maintain adequate mixing, adequate crossing over of red blood to the systemic circulation to sustain life. So a child with an intact ventricular septum and an intact atrial septum is not going to survive with just a PDA, because the PDA generally is a systemic to pulmonary shunt. And what we're trying to accomplish is blood getting from the pulmonary circulation over to the systemic side. And there's very little bidirectional shunting possible with most PDAs. How does the red blood get to the aorta when we have transposition? And while the ductus may be an important adjunct to let this happen, it's absolutely essential to have an intracardiac level of shunting. Now, a ventricular septal defect can be a very large mixing lesion where blood coming in to both ventricles can spill across in both directions across a ventricular septal defect, and that often results in quite good mixing, quite good exchange of blood, oxygenated blood going over to the aortic side. The atrial septal defect is what usually is thought to be essential. It's blood returning to the venous sides of the heart on each side can stream from the pulmonary venous side from the left atrium across to the right atrium, which is the typical direction of shunting at the atrial level when you have increased pulmonary blood flow, and then that can go out to the aorta. So the real question is, how do you get increased pulmonary blood flow? And in many of these kids, the pulmonary blood flow will be elevated because pulmonary resistance drops. And the reason why the ductus can be such an important adjunct is in the first hours or days of life, pulmonary resistance still may be elevated. But with the ductus, we can have increased pulmonary blood flow. The typical direction, again, blood flows through a ductus is aorta to pulmonary artery. That increased pulmonary blood flow leads to increased pulmonary venous return, so the left atrium is volume loaded. And even though the atrial septal defect that most people are born with is designed not to shunt left to right, but right to left. With a volume-loaded left atrium, we'll get more blood forced left to right across that atrial septal defect, which then can head out to the body via the aorta. So that the ductus is an important adjunct, but it truly relies typically on a decent atrial level shunt to accomplish its goal in improving oxygen saturation. And that's why it's so vitally important when we recognize either prenatally or immediately upon birth, if the atrial septum is restrictive, that needs to be addressed relatively urgently. Increased blood flow to the lungs from a ductus can force more blood flow through a somewhat restrictive atrial septal defect, but true stability can be only gained when that atrial septal defect is larger, and thus the reliance with most of these patients on the ability to relatively easily open up the atrial septum with a balloon catheter technique. So how do these kids present? The classic description of the babies is that they're cyanotic with what's termed comfortable tachypnea. They aren't cyanotic because they have lung disease. Their lungs are perfectly normal, so they're not distressed. They're not breathing hard necessarily, but they're tachypnic because the low oxygen level drives hyperpnea. With a VSD, because usually there's more mixing allowed at a VSD, the cyanosis may be less evident, may be unrecognized just on clinical exam. And these kids will classically develop congestive heart failure symptoms within weeks, usually even a more accelerated course than a child with a VSD with normally related great vessels. And how do we diagnose transposition? Well, echo, as with many of the congenital heart defects we deal with, is the principal diagnostic method for making the diagnosis and also delineating the key anatomy. And typically with transposition, echo is all we need to be able to plan our management moving forward. Now, echo is going to show us the anatomy of the great vessels, which is obviously key to making the diagnosis. And more detail about the anatomy of the great vessels is their relationship to each other. The typical orientation of the great vessels with transposition is the aorta is anterior to the pulmonary artery and slightly to the right. It's important to identify the cases where there's a little more of a side-by-side orientation. We may see this in cases where it's more variants that lean toward double outlet right ventricle, but one of the important reasons to identify a more side-by-side relationship is that usually that's going to be associated with something more unusual with the anatomy, something more complex. And specifically when we get to identifying the coronary anatomy, it is also going to be associated with more variations in more presence of some of the unusual coronary variations. So the coronary arteries aren't very smart. They're going to take the fastest course they can back to the aorta. And if the great vessels are more side by side, that may end up resulting in a more unusual coronary branching pattern than what is typically seen. So in addition to the great vessel anatomy and orientation, we want to look at the septi. Again, I've mentioned the crucial importance of identifying an adequate interatrial septal communication. And the presence of a VSD is important to look at. And some of these kids, because they may not have a lot of shunting at the ventricular level, they may be difficult to identify a small VSD. And that's important to get a handle on. And it's sometimes worthwhile going back and echoing a day or so later, because any ventricular septal defect, other than something very tiny, ought to be addressed at the time of the definitive operation to deal with transposition. And then finally, the coronary anatomy. The coronary anatomy is crucial in terms of operative planning. And the important aspects of the coronary anatomy are usually completely definable by echo. You don't need any fancier studies. The things that are crucial about the coronary anatomy are there two arteries? Are they originating from the centers of the respective sinuses of Valsalva? And second, is there any coronary that has an intramural course between the aorta and pulmonary arteries? The other aspects of branching of coronary arteries we'll talk about in a few slides. Yes, that's important, but it's not necessarily critical for surgical planning. And so even though that aspect, as we move further away from the aorta, the branching pattern of the coronaries and the course of the coronaries, may be difficult for echo to ascertain, the real critical aspects that need to be nailed down are the origins, whether they're two, whether they're central in the sinus of Valsalva, and the presence or absence of an intramural course. Echo can be very helpful in performing the balloon atrial septostomy. Many centers will prefer to go to the cath lab to do atrial septostomy in the cath lab under fluoroscopic guidance. Many centers prefer to do it at the bedside in the ICU with echo guidance, and echo can adequately guide the positioning of the Rashkin balloon, watching it come back across the septum, and immediately document that you've got an adequate intraatrial communication. And then for some other cases, more complex cases, cases that may have had a delay in diagnosis or a delay in surgical treatment, and there's concern that the left ventricle has become deconditioned, echo can give us a fairly good idea on the readiness of the left ventricle to be able to suddenly assume systemic workload, and by measuring left ventricle mass to volume ratios. Catheterization is used selectively. Now, the cath lab may be the way that folks go with the balloon septostomy, but from a diagnostic standpoint, there are cases where catheterization can be useful. Some would argue that you can get better visualization of the coronary arteries angiographically. Now, the angiographic technique for showing coronaries in transposition is not what you would expect in older patients. You're not going to be able to do selective coronary injections in a newborn. The technique for best visualization of the coronary branching angiographically is passing a Berman catheter antegrade out the RV, out the aorta, blowing the balloon up in the ascending aorta, and then with the Berman, the dye is injected below the balloon so it fills the aortic root only, and with a very steep laid-back orientation of the cameras, you can get essentially a cross-sectional view of the aortic root, which can nicely demonstrate the branching pattern of the coronaries. But I would argue that it sometimes is a little bit lacking in really showing the origins of the coronaries and really being able to adequately differentiate an intramural course, whereas echo is far superior in my mind to demonstrate that aspect. So again, the distal branching pattern may be interesting and it may be important from a prognostic standpoint, but less important from a surgical planning standpoint than what can be seen with echo. In some unusual anatomic variations, catheterization may be helpful. Sometimes we've employed CT scanning or MRI if there's concerns about arch anatomy, and that's a good adjunct study for defining the anatomy. And then, again, catheterization can be used diagnostically in older infants or children where arterial switch is still preferred but has been delayed, where we want to assess the readiness of the left ventricle that has been the pulmonary ventricle for a while to take on the systemic workload. Now, people focus a lot with transposition on coronary artery patterns. And as we'll see in the next slide, it's important because since the beginning of experience with the arterial switch operation, people have recognized that the real challenge with the operation is moving the coronaries, and most of the risk and most of the successful outcomes are hinging on being able to move those coronaries successfully so that they maintain adequate myocardial perfusion. And a lot of papers, a lot of textbooks have these diagrams similar to what's on the slide here, showing all the variations of coronary branching patterns. Sometimes they'll be shown with this projection, which is what people refer to as an echo projection, as if you're standing at the patient's foot looking up toward the head. So it's kind of the bottom view of the great vessels. Most surgeons prefer a different orientation when you're looking from the top down. The upper left panel, panel A, shows what we consider to be sort of typical coronary artery branching. It's very similar to normal branching pattern of coronary arteries in normal anatomy, where there's a left main coronary giving off a left anterior descending and circumflex, and then there's a right coronary artery. Each come off from their own sinus of Valsalva. In transposition, the most common variation that we see in 2/3 of the patients with transposition mirrors that pattern, where there's a left main giving off an LAD and circ. We have a right coronary coming off the right. The naming of the sinuses, there are a couple of systems. I find the most helpful of just referring to a left-facing, right-facing sinus. One thing I don't like about this diagram is it almost draws these great vessels in a almost side-by-side orientation when normally they're a little more front to back. With the pulmonary artery and the aortic valve, there's always a commissure of the respective valves that face each other. That's the way these valves develop, which leaves two sinuses of Valsalva, which are kind of facing the other great vessel, and one sinus of Valsalva, which is non-facing or opposite. And then if it's a more front-to-back orientation, we can identify those facing sinuses as either the one on the left or the one on the right. So typical coronary branching pattern would be described as LAD and circ from the left-facing sinus, RCA from the right-facing sinus. 2/3 of patients will exhibit that variation. The next most common variation is the circumflex arising with the right coronary artery. So RCA and circ from the right-facing sinus, LAD from the left-facing sinus. And that's something you may expect to see more commonly if you do have a little more side-by-side orientation. The circumflex supplies the back of the heart. If the aorta is a little more off to the side, it may be a quicker shot to get to the aorta on the right-facing sinus than coming all the way around the front to the left-facing sinus. And then there's other variations which are described and seen far less frequently. A single coronary artery giving off all three major branches is probably the next most common variation after these first two, which represent nearly 3/4 of patients. And then other variations, and some people will refer to as looping orientation of the coronaries. If, say, the left coronary that goes to the left distribution comes off a right-facing sinus, that's a posterior loop. If the right coronary that goes to the right distribution comes off the left-facing sinus, that's an anterior loop. So people describe those loopings. And then these two panels down here demonstrate the intramural course. An intramural course is where one of the coronaries arises from the opposite facing sinus of Valsalva, often very near the commissure of the valve, but then takes an intramural course between the great vessels. And that's why this is something that should be identifiable by echo. You should never see a coronary going between the base of the great vessels. And if you do, you've got to worry about an intramural course. And that can be the right or the left. It can just be an LAD. The circumflex can come off with the right. A lot of different variations. But these are the ones that we typically worry about the most in terms of risk. And this is a study that talks about translating those coronary patterns into outcomes risk. This was a study published in 2002 in Circulation. It was a meta-analysis of a number of different reports of arterial switch for transposition. Almost 2,000 patients were included. And they looked at the various coronary patterns and tried to identify, were these patterns higher than typical anatomy risk or lower? And they also segregated things into two eras. They looked at pre-1992 and post-1992 because really the 80s and early 90s represented the first decade of the arterial switch operation, and many centers were still going through a learning curve. A lot of these complex and unusual coronary variations were clearly a challenge. People hadn't devised techniques or really disseminated the information about these techniques widely, so frankly, people had a lot more trouble dealing with them. But after 1992, most centers, most surgeons had at least seen a lot of these variations or seen reports of how to deal with these, and certainly if you have the information going into the operating room, you've been able to research it in the literature and be better prepared to manage these things. And so on this diagram, we have the odds ratio of 1 would mean that any of these variations would be equal in risk of outcome for mortality to standard coronary anatomy, which is, again, the left and the circumflex coming off left-facing sinus, right coronary coming off right-facing sinus. Virtually all of these variations are, with the exception of this one being virtually the same risk, are higher risk, with singular exception of this any coronary looping with a single ostium in the current era seem to be a better outcome than standard anatomy, although, as the asterisk delineates, this was a very small group of patients and there were no mortalities reported. But because of the small size, the confidence intervals are very wide. So that's a little subject to skepticism, but what we do see is with some of these looping patterns, the risks are a bit higher, but they've come down in the current era. People have been able to deal with these more effectively, where they're very close to that of standard anatomy, particularly when we have looping patterns but with 2 coronary ostia. It really is virtually identical to standard coronary anatomy. But these intramural variations have always been elevated risk. It has certainly come down in the more recent era compared to the first decade of arterial switch, but still pretty far off that index line. And what's important to recognize is this scale is a logarithmic scale. So in the current era, intramural coronaries still has a risk that's upwards of 6 times standard anatomy. Used to be upwards of 10 or 11 times. So that's what's important. And again, any variation in coronary anatomy is going to be an odds ratio about double the risk of mortality compared to standard anatomy. So that's why we focus so much on understanding the coronary anatomy. It helps us prognosticate, but it also helps us prepare to deal with these things using some sometimes quite inventive techniques to dealing with the coronary artery translocation. So how do we manage these patients initially? It's by and large pretty standard practice to initiate prostaglandins, but some centers don't. It partly depends on where the child's born and how far they've got to go to get to your center. If you've got deliveries in your center and you choose to decide if the child's known to have an adequate atrial septal defect, or you can define that right away, you may choose not to initiate prostaglandins and see if they need them. Certainly patients that are born at a distance from the treating hospital and they're going to have to be transported, it's going to be far safer to have prostaglandins running in case they have desaturations as the duct closes, if that happens on the early side. Most surgeons are going to want to opt to try to get the prostaglandins off if possible. If we're not going to go to the operating room in the first day or 2 of life, and if we can allow the ductus to close and it's tolerated, which we really frankly only see in about 50% of the cases in my experience, it's nice to have the ductus close some, because as we'll cover in a little bit, in order to do the arterial switch operation, to move the pulmonary artery and the aorta in opposite positions from one another, we have to disconnect them completely from one another, which involves dividing the ductus arteriosus, not just ligating it, dissecting the whole thing out, ligating it, both ends, dividing it. A ductus that's been in a child that's been on prostaglandins has the consistency of wet tissue paper. And it's one of the scariest parts of the operation to dissect that ductus when it's big and it's friable and it may fall right apart. Having a chance for that ductus to close even a little bit, even for a couple of days, makes the handling of that ductus far safer, far less risky. Balloon atrial septostomy. Some centers routinely will have a very low threshold for performing balloon septostomy in virtually anybody that is even the least bit cyanotic, any patient that requires prostaglandins to try to get them off of that. And some centers are really hesitant to use septostomy. I think you have to be aware of your team and the experience that they have. There was a paper a number of years ago which pointed out significant risks with balloon septostomy, particularly cerebral vascular injuries. I think with an experienced team, with good techniques, the incidence of complications with balloon septostomy are quite low, should be quite low. And my personal bias is I have a very low threshold to recommend balloon septostomy if the child's the least bit cyanotic off prostaglandins. And even if certainly if they're cyanotic on prostaglandins, it's something that should be taken care of urgently. And then we define the anatomy. Once the child's stabilized, we have the chance to define the anatomy. And again, that's typically going to be relying on echocardiograms. And then the timing for surgery is usually in the first week of life. And early in the experience with transposition and arterial switch operations, it used to be written that you want to do the arterial switch for kids with intact ventricular septums in the first 2 weeks of life, with a VSD anytime in the first 2 months of life. A lot of that came from the fact that you want to make sure that when you do the arterial switch and you're changing the role of the left ventricle from pulmonary ventricle to systemic, it's going to be able to tolerate that acute change. And with an intact ventricular septum, that left ventricle, being a pulmonary ventricle, is going to atrophy more rapidly. But in the first 2 weeks of life, it's predictably able to switch jobs right away. Beyond that, many times it'll tolerate it, but it's less predictable. With a VSD, it's going to maintain systemic level pressures, even if it's pumping to a lower resistance circuit. And often, from a standpoint of left ventricular preparation, you're going to have a little more leeway. But by and large, nowadays, transposition, whether it's VSD present or an intact ventricular septum, it's going to be managed surgically in the newborn hospitalization, typically sometime in the first week of life. This graph's from a study that was published out of Columbia in New York City. They were trying to look, is there any specific sort of date of life that is best outcomes? And they sort of sliced and diced their cohort of 140 patients with transposition in a lot of different ways. They broke them down by different birth weights, by whether they were born on weekends, weekdays, and tried to identify outcomes. And they didn't look at mortality so much because the mortality rate was very low. They had a composite score of major morbidity, and the major morbidity included things like cardiac arrest, need for ECMO, delayed sternal closure, systemic infection, necrotizing enterocolitis, CNS complications, paralyzed diaphragms, and reoperation before discharge or readmission in the first 30 days of life. Now, some might argue some of those complications have nothing to do with the timing of surgery, like paralyzed diaphragm. So it's kind of an odd mix of things. But what they found was that no matter how they subdivided their groups of patients based on when they were born and things like that, they seemed to hit a nadir in risk of this composite morbidity score at about 3 days. And certainly before 3 days of age, if the patients were operated, their incidence of major morbidity seemed to be higher. And beyond 3 days, it stayed low through the rest of that first week of life, but then certainly started to rise at about a week of age. And it led them to conclude that it probably isn't wise to just rush off to the operating room in the first day or two of life, but certainly mid to late first week of life is going to be associated with a low risk of morbid outcomes, but beyond a week it may start to rise. Now, one of the criticisms of a retrospective study like this is we're just looking at association, so you don't know for sure, is the morbidity a result of waiting, or was waiting a result of the fact that they had a morbid condition? And to the author's credit, they really did try to control for delays that were related to pre-op morbidities. They really tried to filter those out so that isolating the fact that, yeah, these delays seem to result in morbidity rather than the delays resulting from morbidity. So the surgical management of transposition of the great arteries has an interesting history. Open heart surgery was first used for any heart lesions, remember, in the early 50s. 1952 was the first use of the heart-lung bypass machine by Gibbon to close an atrial septal defect. And within a decade, people were tackling complex lesions like transposition of the great arteries. But during that decade, we were still looking at operating on older children, not newborns, and the options for managing these kids, although people tried things like switching the great vessels without moving the coronaries, as one might expect, weren't very successful. And it was Aki Senning in 1958 who published the first successful surgical correction, physiologic correction, not anatomic correction, of a child with transposition using his atrial baffle technique. And so this was a real breakthrough. And unfortunately, a lot of people didn't jump on the bandwagon because they couldn't understand what the heck he was doing. And this diagram on the slide is from his original description, and it's a very schematic cross-sectional depiction of what the operation entails in creating these almost atrial baffle pathways that are sort of concentric, one around the other. And people couldn't really understand what he was doing. I've been told that Dr. Senning had an incredible ability in his mind to reconstruct and visualize things in 3 dimensions. So he could understand what he was trying to do, but it was really difficult to describe it to an artist and have an artist's rendition that other surgeons could say, I understand what you're doing there. And so it really didn't have a lot of people subscribing to this technique. It was really a couple years later, in 1963, when Dr. Mustard from Toronto described similar concept, a little bit different technique, and one that people could understand a bit better. Instead of creating cuts and flaps with atrial tissue, he opened the atrium, cut out the atrial septum, and then using a patch typically of pericardium, kind of a horseshoe-shaped patch, sew it in place as depicted on the dotted line, so the superior and inferior venous blood is directed across to the mitral valve, and the pulmonary venous blood spills over that pathway to the tricuspid valve, thus rerouting the atrial flow to correct the physiology. And people understood that better and adopted that more quickly, but then ultimately came to realize that this pathway made of patch material could sometimes develop stenoses if the pathway patch didn't grow, whereas Senning's technique, which was relying predominantly on all native tissue, didn't seem to have as much problems, and ultimately people finally figured out what he was talking about, and in many places the Senning became more popular than the Mustard procedure. But certainly through the 60s and 70s, that was the treatment of choice for transposition, and the results were good. And the picture in the lower right shows Dr. Mustard celebrating with one of his first successful Mustard procedure patients many years down the road, an excellent long-term outcome. But as we know nowadays, we deal with this anomaly using the arterial switch operation, and that was first pulled off in 1975 by Dr. Jatin from Brazil. It was actually first published in a Brazilian medical journal in Portuguese, and so it didn't have a big impact immediately. Within a couple years, though, a report in the English literature, one of the major cardiothoracic journals, did appear, and so people knew that somebody had pulled this off. And it was important to recognize that it wasn't just an incredible surgical feat, which it was, but it was also on the background of a lot of other things that were going on to allow something like this to happen. Remember, newborn intensive care units really didn't exist before the 70s. We didn't have the capability of taking care of babies in an ICU setting much before the mid-70s and 80s. Our diagnostic tools, echo, really were maturing in the 70s and 80s. The ability to be able to do heart-lung bypass using techniques such as deep hypothermic circulatory arrest, could be applied to newborns. So the whole field of newborn open heart surgery just started to develop in the 70s and really matured in the 80s with folks like Dr. Castaneda in Boston, Dr. Barrett Boys in New Zealand, who really started newborn heart surgery end of the 70s, early 80s. So it was on that background that Dr. Jatin published his first successes with an arterial switch operation. And then the team in Boston quickly followed suit, and in 1983 published their first experience, which I think was 11 patients, with good outcomes of newborns undergoing an arterial switch. And that ushered in the modern era of dealing with transposition. And for a while, it was really tough. A lot of centers weren't adopting this because here we had an operation, the arterial switch, which in its early days had a high mortality. It had a steep learning curve. And so patients, many centers were achieving 70% survival, where on the other hand, you had an operation that you knew long-term may not be ideal, a mustard or a Senning, but had a 95% survival rate, perioperatively. So the transition to an arterial switch operation, even though logically it made sense, was a little bit slow in coming even after this landmark 1983 publication. But folks learned how to do it and got over their learning curve, and then by the end of the 80s, it was totally switched to that everybody was doing arterial switches. The survivals were matching that of the atrial switches, the mustards and Sennings, and as they say, the rest is history. So what is an arterial switch operation? As the name implies, we switch the positions of the great vessels. The aorta, which is coming off anteriorly, is divided above the level of the valve. The pulmonary artery also is divided above the level of the valve. We can't move the valves. We have to leave the valves intact. We have to preserve the native valves in their positions with good function. Just taking those blood vessels apart, switching their position, sewing it back together, that's pretty straightforward. These are the biggest blood vessels in the body. That should be pretty straightforward even in a newborn, and by and large that is. It's the fact that you have to move the coronary arteries and you have to move those separately that is the challenge in an arterial switch operation, as we've kind of alluded to in previous slides. So the coronary arteries are typically coming off the center of their respective sinus of Valsalva. We take a large button of that sinus of Valsalva very close to the valve, but as much arterial button as we can with that coronary. So we're not just sewing a coronary ostium, but sewing a larger button of tissue, which keeps us away from sewing right near the coronary ostium itself and also gives us some more flexibility. These buttons can sometimes trumpet a little bit, if you will, and give us extra length and accommodate for a little bit of shift or torque in the rotation of the vessel when we move those back. So those are harvested, the proximal coronaries are mobilized, and they're attached to the posterior great vessel, usually a little bit above the sinus of Valsalva or in the top parts of the sinus of Valsalva. And then the aortic reconstruction, the neo-aortic reconstruction, is continued by sewing the distal aorta to that reconstructed proximal neo-aorta with the reimplanted coronary arteries. It's important to notice as distally, the great vessel position has changed. The pulmonary artery distally, the bifurcation, is pulled in front of the aorta, the so-called Lecomte maneuver, because these vessels are usually front to back. It's the best way to bring those into different position without kinking the branch pulmonary arteries. And then finally, reconstructing the neopulmonary artery, the place where the coronary buttons were harvested, need to be reconstructed with a patch. This diagram isn't quite correct because anteriorly there's going to be there wasn't a coronary harvest, so you've got a sinus of Valsalva which is completely intact. It's the back 2/3 of the neopulmonary artery that is reconstructed with what's usually referred to as a pantaloon patch, one with a leg that goes down each sinus of Valsalva. And then the distal pulmonary artery is anastomosed to that patch posteriorly, but to native tissue anteriorly, and that's what we're relying on for growth. And so when we look at the compare and contrast table here about outcomes for arterial switch and atrial switch, the mustard and the Senning, this is sort of best case scenarios from many papers over many years, from the heydays of mustards and Sennings and the modern experience, if you will, with arterial switch operations. And again, hospital survival perioperatively were really good with both techniques. Now, again, with arterial switch, wasn't the case during the learning curve, but nowadays, hospital survival of 95% should be expected with an arterial switch, and that's what people were achieving back in the 80s with the mustard and the Senning operation. Late survival is excellent with arterial switch. It makes sense. We're fixing the physiology, but we're also doing it with reconstructing pretty normal anatomy, and not surprising, there's good late survival. However, with the mustard or Senning, we may be fixing the physiology, but we're still leaving the right ventricle to be the systemic ventricle, and that has an impact, along with other things, on late survival, and that starts to tail off. The rate of reoperation is really low with both options and always has been. But again, the late ventricular failure, when you've got a systemic right ventricle, starts to mount up, and that's where we start to see late ventricular failure of 10 to 20%, which is going to be responsible for that drop-off in late survival, by and large. And then also an important distinction is the risk of late arrhythmias. The risk of arrhythmias after arterial switch is very low. Probably most of that is related to AV conduction related to children with ventricular septal defects and the risk of injury to the His bundle with that. With the mustard or a Senning operation with complex intraatrial baffling, a lot of cutting, a lot of suture lines, it's a setup for atrial dysrhythmias, atrial fibrillation, atrial flutter. Some folks have said it's basically an incidence that approaches 100% if you follow these patients long enough. And that can contribute to a significant amount of the late morbidity with the mustard or Senning operation. Now, if we look at survival curves, this was an interesting article that was published about 5 years ago from the Netherlands. They had looked at a fairly good population they had of mustard procedures, nearly 100 patients, that they had done a long-term follow-up study a number of years ago. It was published a couple decades ago, where they did a battery of follow-up exams at about 20 years, and then they redid the study more recently with their arterial switch cohort, which was smaller cohort, about 30 patients, but similarly they were able to bring them back at 20 years. And this battery of tests, including a physical exam and a history, but also Holter monitoring, echocardiograms, MRIs, bicycle exercise tests, they got BNP levels, they did quality of life questionnaires, so a fairly comprehensive evaluation of how the patients were doing late after their surgical management. All of the patients over 20 years follow-up. And so the mustard patients had been operated on between 1973 and 1980. The arterial switches had been done between 1985 and 1990, but still all with 20-year follow-up. And what they found was, and these obviously patients that survived, didn't compare the hospital mortality, but we can see that the survival for arterial switch operation is almost a straight line. Late survival, there was very little fall off, but with the atrial level switches, they did have fall off, particularly in the first 10 to 15 years. There was some attrition, and then things seemed to level off just from a survival standpoint. When they looked at subdividing these groups a little bit more, subdividing each of the groups into complex or simple anatomy, where simple would be intact ventricular septum, complex would be VSD, arch obstruction, things like that. As you might expect, the patients with arterial switch with simple anatomy had fared the best, and the ones with more complex anatomy fared the worst. And this is event-free survival, so it's not only mortality, but other adverse events, reoperations, transplant, things like that. And when they looked specifically at the reasons for failure, it was the things that we had on that prior slide, a lot of them are related to rhythm problems where, virtually all of the arterial switch patients at 20 years were in normal sinus rhythm, whereas only 60% of the atrial switch, the mustard patients, had normal sinus rhythm. And when you looked at exercise capacity, when you looked at New York Heart Association class, it was markedly different in terms of quality of life indicators for the atrial switches compared to the arterial switches. And this is a more recently published study just at the end of 2018, which was a look back at the Pediatric Cardiac Care Consortium database, which enrolled patients for many years, a number of centers, and they looked back at the patients that were enrolled in this database between 1982 and 1991. They were looking specifically for that decade where there was the changeover from doing atrial level switches to arterial switches, and then trying to get some late follow-up data. So as this bar graph represents, the arterial switches are the black bars, and we can see in 1982 none of the patients in the consortium database had an arterial switch, and it was roughly even-steven between mustard and stenting operations that were reported. But then as we progressed through the decade and people started adopting arterial switch, by 1991, the last year in this study, 90% of the patients had undergone arterial switch and only a few atrial switch procedures. And so they did some survival curves, and 20, 25-year survival curves, and this is survival from diagnosis, so it included perioperative mortality. And we can see for both the arterial switch, which is the black line, and the atrial switch, which is the purple line, there was a steep mortality right away. That's the surgical mortality. They found that hospital mortality for arterial switch, again, in that first decade during the learning curve, was 21%. For the atrial switches, the mustards and the stentings, it was 13%. So both of them had a moderately steep surgical mortality, but far worse for the arterial switch. But then as they followed out, again, like we saw in these other slides, the survival for the arterial switch remains relatively constant, but there's a late attrition for atrial switches. And at about 10 to 12 years, those lines cross each other. When they redid the survival curves, just looking at hospital survivors, knowing that nowadays this may be more reflective of what we see now, because we would expect for either of these operations done in the current era, the survival through the operation should be better than 95%. When you look at hospital survivors, again, as was demonstrated in that last slide, you get a really constant curve with very little attrition on 20 and 25-year follow-up with the arterial switch, but a progressive decline with the atrial switch, with survival in the 80s out 20 and 25 years. And so if patients have problems, even if they survive, are there late problems that come up after the arterial switch? And certainly there are. And most of them are related to the right side of the heart. The Mayo Clinic looked back at a 27-year experience, and they found in their population there was about an 11% reoperation rate. Now, some of these reoperations they reported were patients that had undergone arterial switch elsewhere, but they were just, their rate of 11% reops was for patients that had been operated at their center, which was 20 of the 32 reoperations. They had done 182 arterial switches in this time period, but they were just trying to characterize what are people coming back for when they need reoperation. And as we can see, about half of them are pulmonary artery plasties, supravalvular pulmonary stenosis, so the area that had to have a prosthetic patch, or it's often pericardial patch, but a patch reconstruction for part of that. Not surprising, there were problems. And early in the experience with arterial switch operations, the incidence of supravalvular pulmonary stenosis was as high as 25 and 30%. And there were a lot of studies trying to identify what was responsible for that, and frankly, none that really definitively identified what was causing these. But ultimately, the incidence went down, and I think, in my mind, one of the big features that lowered the incidence was people would learn to be much more aggressive dissecting out the pulmonary arteries all the way out to the pulmonary hyla, so that anastomosis is tension-free. And nowadays, the incidence of supravalvular pulmonary stenosis is probably in the 5% range, about a fifth of what it was in the early experience, but still accounts for about half of the reinterventions. Aortic valve was slightly less than a quarter in their experience. Pulmonary valve replacement, about 10 to 15%, and then operations related to coronary arteries or the mitral valve made up the rest. And some patients underwent multiple reoperations. About half the patients that were reoperated had other reoperations, and again, these tended to conglomerate on the right side, fewer on the left side, and then a mix of other reoperations in these patients. A lot of people have focused on dilation of the neo-aortic root. It's originally was designed to be a pulmonary valve and a pulmonary artery. We've changed its job to the systemic side of things, higher pressure. Maybe it's not too surprising that it dilates, and people would worry, well, if that dilates, is that going to result in aortic valve incompetence? And these graphs are from a study done by Milwaukee Children's. They looked at 124 patients undergoing arterial switch with a median follow-up of over 7 years. And they looked at a couple of things. They looked at the aortic root at a couple levels. This is the aortic root, so at the level of the sinuses of Valsalva, they looked at the diameter over time, and the diameters went up, and that's not too surprising because kids get bigger over time, and so their aortic roots are certainly going to get bigger over time. But when they normalized things as aortic root z-scores, they still saw a rise in the size of the z-score of the aortic root as years went on. So it's getting bigger, a little bit out of proportion to the growth of the child. And it's important to also recognize that the low point even is above 2. So, the population norm would be a z-score of 0, and 2 is 2 standard deviations from the mean. So you're already starting out on average a little bit bigger than the upper limits of normal, but it still rises. And again, this is at the level of the sinus of Valsalva. And that may contribute to aortic insufficiency. If the top of the valves is being splayed out, that can be a problem. A lot of people are going to focus a lot more, though, on the annulus at the bottom of the aortic root, at the junction with the left ventricle. Is this going to be associated with dilation? And that would more predictably be associated with aortic insufficiency. So looking at the neo-aortic annulus diameter, and again, as one would expect over time, the annulus diameter is going to increase. And when you look at the z-score, though, correcting for patient growth, that stays relatively constant. And again, starting out larger than the population norm, but not necessarily increasing in diameter. When they looked at the freedom of regurgitation or dilation, they showed this gold bar, which shows that over time, up to 20 years, the freedom from dilation was pretty low. Virtually all of these patients got dilation of their aortic root. And a lot of them, not quite as many, developed neo-aortic regurgitation. So at about 20 years, there was a 60% freedom from neo-aortic valve regurgitation. So 40% of these had important regurgitation. But even out this far in this experience, none of these patients were bad enough to require reintervention. So that's certainly something we worry about long term, is the neo-aortic dilation resulting in incompetence, which may ultimately result in the need for aortic root replacement, aortic valve replacement. But so far, at least in the first decade or two of follow-up, not a common occurrence, at least not to the point where the valve needs to be replaced. And so that ends the discussion. Thanks a lot for your attention.